We'll get going so that we make sure we have enough time for some good discussion. I also have a tendency to talk too much, so Jess is going to give me the cutoff point if and when I'm doing that. Yeah. So again, our agenda for today is, first I'm just going to give a bit of an introduction to newborn screening, both around the blood spot screening system as well as the hearing screening system. Ari is then going to talk about congenital CMV, congenital CMV disease, and the clinical care and management of that. Jess Dunn is then going to talk about the overview of the actual CCMV screening positive care pathway, and we're hoping to have a good at least half hour for discussion and questions and discussion of logistics in this area, et cetera. Reminder that this, thanks to Lauren's hard work, was accredited as a group learning activity under the Royal College MOCOMP, and for 2.75 hours as an accredited group learning session. And you'll be getting a certificate by email after that. Okay, so then my slides. Introduction to newborn screening in Ontario. First of all, disclosures. I actually don't have any disclosures right now. In terms of learning objectives, first to describe the process and a bit of the history of newborn screening in Ontario. Summarize some of the rationale for the expanded hearing screening, which is really what we're here to talk about today. And then discuss the importance of early identification and intervention of infant hearing loss. So the first slide I replaced was this one. So in terms of a definition of screening, I think we all intuitively understand what screening is, but to actually sit down and try and define it can be difficult. Well, there it is, 2012. So 7 years ago, we actually had a task force. So it was 8 years ago. It took us 6 months, a lot of debate, literature review, et cetera, to try and answer a question we had received from people at the Ministry of Health to define what newborn screening was. Some of the early debate was, does it mean that you're screening newborns for a disease in the newborn period? What about screening in the newborn period for a disease no matter when it appears? Is it about disease? Right? There were a lot of differences of opinion that were actually unsaid and uncommunicated, where people were coming from very different perspectives. So when the government was getting advice on what was screening, they were getting advice from those different perspectives, and we're the ones who were actually able to point out to us that we were all speaking a slightly different language. There's a couple of really important things in screening. So here's the definition we came up with. Screening is a systematic, population-based application of a test or inquiry to individuals who do not have symptoms of a specific disease or condition in order to identify those who warrant further investigation and or intervention to achieve a better outcome. So it's a really loaded definition, which is what happens when you have, a 6 month, process with 10 people trying to come up with that statement. But there's some key points in there. You're dealing with an asymptomatic or minimally symptomatic population, which is different than what we usually are encountering in our day-to-day clinical practice, where people come to us because they have a concern or they have a symptom or they have an issue that they need our assistance or advice on. The second is it's about risk estimation. You're trying to move a person who's at a population risk by definition and move them into a higher risk group where they may benefit from interventions to improve some sort of outcome. So after you've done that risk estimation, then you have to go to diagnosis and you have to go to a further decision process as to who needs treatment, who doesn't, et cetera. And it's about outcomes. So in the end, this is all really about early identification where you can change something to achieve a better outcome. So screening equals better outcomes if it's done well, if it's done properly, if it succeeds, is about better outcomes from starting treatment early in the course of a disease. Okay. So in terms of NSO, I think we're all very familiar with the dry blood spot screening. It's been in place since about 1965, started with PKU, collected at 24 to 48 hours of age, usually at the birthing hospital or by a midwife at home. And screens for about 25 diseases, all of which share a commonality in that they're quite rare individually, and fulfill those criteria that I mentioned before. There's a treatment, you can improve an outcome, et cetera. There's also now pulse oximetry screening, which began a few years ago. Robin led the charge in the province in the implementation. The big difference here is not in the overall philosophy or the purpose or even in terms of the overall structure of a system of reaching infants and whatnot. The biggest difference here is now you're doing a test at point of care. You're doing a test right at the site and have your whole decision-making process in place at the site. And so the role of NSO is different. It's not performing or doing the test, but rather providing support regarding standardization, quality assurance, accessibility, et cetera. Hey, this was the other one I changed. I just put this in because it's my kids. So this was my this was my first baby. My first quality assurance project is what I lovingly call them. So this was her getting her heel prick at the Queensway Carleton Hospital. This was her perfect blood sample. The tech did a great job. Little Band-Aid here. This was actually getting her autoacoustic emission screening in hospital at 24 hours of age. So it was done right after her blood spot was done. And she passed, she did not refer. This I always put in, this was her brother who's now in my lap here. So to remind them, most of the diseases we test for are genetic actually, and that there's some sort of recurrence risk that's possible, and you always have to think about the family. And this was on Father's Day, so I just put that on. At the Lieutenant's Pump, my favorite pub. And that was the third one. Okay, I'll stop. So this is a brief history of newborn screening in Ontario. So in 1965, newborn screening for PKU began out of the public health branch of the Ministry of Health. The lab was in Etobicoke, and that's where the public health labs were at the time. Nothing much changed until 1978, when a second disease was added as a target, congenital hypothyroidism. And that really is a Quebec story where a lot of the research and a lot of the validation and proof that this is going to change outcomes for kids with congenital hypothyroidism was done in Quebec. Nothing much changed again until about 2006. And in the 2 to 3 years prior to that, there were a couple of factors that were forcing Ontario to make some decisions on newborn screening. One of the major ones was that the test that was being done for PKU relied on, it was the same test that had been used since 1965, and the reagents that you needed were no longer going to be manufactured because we were one of the last jurisdictions in the world using that technology. So there had to be a shift. Also, MCAD deficiency, it's a fatty acid oxidation defect where there's a risk of early death due to hypoglycemic encephalopathy. Most jurisdictions by that time in North America and in Europe had implemented screening for MCAD deficiency. There had been repeated pieces of advice to government to add it in Ontario. That wasn't happening, and the Office of the Coroner actually became involved. And then the Ontario Ombudsman, who asked the question as to why babies were being picked up with their MCAD deficiency diagnosis post-mortem in the coroner system as opposed to the neonatal screening system like most jurisdictions. And I tell that story because that's when I first got involved in screening and had to learn all these things about population-based screening that I didn't know. I was a clinician. Right? So I guess I've been doing it for about 13 or 14 years, and it was really coming out of an advocacy role where I was also, trying to advocate for adding MCAD deficiency. The government, of course, once they decided to move, decided not to stop at MCAD deficiency, but adopted the American Recommended Uniform Screening Panel of 27 diseases. And they had a competitive process to move the newborn screening program out of public health and into an academic pediatric hospital, mainly because they wanted it closer to clinicians and to research. And that's how it ended up coming to CHEO, and that's when my career completely changed from being a clinician and being involved here. We had fairly rapid change since, in those 2 years, going from 2 diseases up to the full panel, with the last one being added in that spurt, being cystic fibrosis. I think a couple other really notable ones, sickle cell disease and congenital adrenal hyperplasia. And really notable because they're not inborn errors of metabolism. Most of the others are. In 2013, it was the first time a disease was added, not as part of that big clump, and that was severe combined immune deficiencies. CCHD screening as the first point of care screen in Ontario was added in 2017 as a one-year rollout. That worked really well. I think in the future we may see more screening move to point of care. That's not a topic of today, but since we're all here talking about it, I think that may be a change over the next 5 to 10 years, maybe closer than later, where some early presenting diseases will no longer be tested in a centralized way, but maybe tested at site. And now we're here to talk about the expanded hearing screening, so I'm not going to belabor that. And in terms of what's next, in April of 2020, we'll be starting screening for Hurler disease, or MPS 1. So in terms of the overall organization of the screening system, this is where we sit at NSO and perform a few of those central functions in terms of the lab, data management, education, quality assurance, development, evaluation, et cetera. Referrals, receipt, right? Babies, where they're receiving their care in their postpartum period, that's where the upstream part of the system lies, and that's where they're entering into the screening process. So again, mainly midwifery care and birthing hospitals are the big players there. And then in terms of the current targets of screening, once a risk estimation has been performed by testing and correlating with demographic information, et cetera, those babies are referred for evaluation and initiation of treatment if needed at regional treatment centers, which reside at the academic pediatric hospitals, mainly because they have to all go directly to subspecialty care if they're affected. All of this exists under the auspice of the Ministry of Health and the Provincial Programs Branch, and we have an advisory council which includes people from Ministry of Health as well as Ministry of CCSS, so it was the old Ministry of Children and Youth Services, Children, Community, and Social Services. Okay, so these are some slides from the infant hearing program, and I'll just speak to the slides. So the infant hearing program was implemented in 2001, and it's a comprehensive program that is both about screening. I think in our minds as clinicians, we usually think of the infant hearing program as the universal newborn hearing screening program in Ontario. That is one element around the early identification of children born with permanent hearing loss. The other elements are actually really in the evaluation and care pathway. And so that's in providing supports and services needed to develop language and early literacy skills, provide the services to children who are identified with permanent hearing loss, PHL, from birth to school entry, and then monitor children who are born with or acquire risk indicators for PHL. And I think that's an important one just to highlight a little bit, is again, we usually think of the infant hearing program as being focused on congenital permanent hearing loss, so hearing loss at birth. But really their scope is permanent hearing loss in the first 5 years of life, so up to age 6. And already do some risk factor screening as well as surveillance to try and pick up kids who are at a higher risk for early permanent hearing loss, and then survey them to try and pick up that hearing loss early. It's organized through 12 lead agencies across the province, and they are the ones who are actually responsible for delivering the care under the stewardship of the MCCSS. Okay, I'm not going to go over this again because I think I've just spoken to it, but it's, again, the universal newborn hearing screening, the concept of assessment and surveillance. I will just put here at the bottom, these three I haven't really mentioned. So one is assistive technology. So the prescription verification and fitting of amplification, i.e. hearing aids, is part of the infant hearing program. Support of language development, and also family support. So again, it's designed as a comprehensive service provision system for children who have who are deaf or hard of hearing. Okay, what are their targets? So the targets for physiological screening, and when I say that, that's actually measuring the physiology of hearing, right? So that's what you're doing with autoacoustic emissions or automated ABR. Um, so the targets are to screen a newborn by 1 month of age, identify those born deaf or hard of hearing by 3 months of age, and start intervention by 6 months of age. And these targets are quite universally accepted and are really based on the existing knowledge of when intervention can be effective in optimizing development in kids who are born or have early onset, very early onset permanent hearing loss. So children who meet these targets can develop language comparable to their hearing peers by the time they enter school. All right, so helping to identify children at risk for PHL. Right now, that's often done by interview or chart review. And some of the risk factors may not be evident at birth. So, later today, we'll be talking about asymptomatic congenital CMV infection, where there's about a 10% risk of permanent hearing loss. Those kids are not apparent at birth, right? Infants who pass the hearing screen at birth but actually have PHL, i.e. false negatives, can be difficult to identify. And that's a potential harm in any screening in any screening system is once you have an effective screening system in place, the probability of a child actually being affected and not being picked up by the screening system is relatively low. So it can actually sometimes perversely delay the pickup of a kid because there's confidence in that screening system. All right, so what are some of those risk factors and how do they intersect with what we're talking about here? The two big ones are congenital CMV infection and genetics. So on the left-hand side is the incidence at birth. On the right-hand side is the prevalence at 4 years of age. This is really a landmark paper in this area, still heavily cited, still a good read. Morden and Nance. So in the hearing world, if you say Morden and Nance, everyone knows this paper. And so one of the things you'll see is that there's roughly a doubling of the from the birth prevalence, so the prevalence of permanent hearing loss at birth to that of 4 years of age. Okay? So currently all the kids who lose their hearing after birth and before 4 years of age are not being ideally or as effectively picked up as the infant hearing program would like. And this is actually a big part of the reason that they started speaking with us and we started working together about 5 years ago, maybe even 6 years ago. It was 2013 late, so to try and figure out if we could do something like this. Another thing to note is that the big players at birth and the big players at 4 years of age remain genetics and congenital CMV infection. In terms of what we're targeting here, obviously today we're talking about CCMV. We're in the genetic side of this targeting two particular genes which account for the largest proportion of those with both congenital and non-congenital permanent hearing loss. And those are GJB2, which commonly or historically was referred to as connexin, as one of the connexin genes, and SLC26A4, which is the most common reason for Pendred syndrome. The screening is not at all going to be 100% sensitive, but is targeted at the most prevalent mutations, the most common mutations that are very well described and known to be very strongly associated with permanent hearing loss. So we're going for a very high specificity screen at the beginning, and then we'll consider whether or not to broaden that. The care pathway, and this is probably all we're going to talk about this one today, unless people want to talk about it more in discussion. The care pathway will really be going down an audiology ENT pathway with involvement of genetics as needed. So it's a very different pathway of care. Most of these kids should be congenitally deaf, but there will be those who won't be and will be anticipated to develop their deafness very early in life. And so we'll need a very different type of surveillance and care. So everything we're talking about here was actually proposed, if you will, in the Morton and Nance paper. So screening for these three causes, They included a mitochondrial DNA point mutation, which I won't get into today, but now that's getting into my area and I could talk for hours about that. If we were to screen for these three causes of late onset hearing loss, as well as cytomegalovirus, we estimate the follow-up of at-risk infants should result in the pre-symptomatic detection of nearly 60% of all infants in whom late onset prelingual hearing loss develops, as well as an immediate etiologic diagnosis for at least 40% of those with congenital hearing loss. Okay, I think I only have 3 more slides. Why are we doing this again? I think this is just something to hammer home a little bit. Jason Brophy, who's, along with Ari, has been, championing this for a long time, put the slide together with Marie Pigeon, who's an audiologist at CHIO. They deliver it way better than me, so that's why I'm doing all this caveat. The bottom line here is that if you have a combination, if you have early identification, you can improve functional language outcomes in a pretty meaningful way. So if you're starting with early identification and normal cognition, your mean language quotient approaches 100. And so this is in kids with permanent hearing loss, right? So I should have mentioned that at the beginning. So this is kids with permanent hearing loss. If they're late identified, so outside of those benchmarks I noted earlier, that 1-3-6 month type of benchmark, if they're noted later and had normal cognition, their language development quotient is at about 70, which is very similar to those who had early identification with cognitive difficulties. And then if you have both, your functional language quotient is quite low. The second, so this is from, again, a very influential paper in 1998. The same group has published a whole series of papers since then, as have others that corroborate these types of observations. A second issue is that this is not static, right? So if you have early confirmed permanent hearing loss and are receiving the services and interventions that are associated with the treatment plan, there is a maintenance of that comprehension level. In the late confirmed, there's an actual deterioration over time. These are the types of observations that really made the infant hearing program very interested in trying to both improve what they could in terms of the detection of congenital hearing loss, but also to try and improve what they could do for the detection of non-congenital but still early permanent hearing loss. Right, and so this is Marie's impact slide. So failing to provide intervention by 6 months is equals the same result as in performance for children with hearing loss and normal cognition that is equivalent to children with hearing loss and cognitive disabilities. Sorry, I said that wrong, I'll do it again. Failing to provide intervention by 6 months, what does that mean, right? If you don't manage that, what you're doing is you're gonna end up with results in performance for children with hearing loss and normal cognition that are equivalent to the children with hearing loss and cognitive disabilities, right? The difference here is the early recognition, the early detection will prevent that level of, that low level of functional performance. And the way they communicate that is creating an environmentally produced cognitive disability. Okay, I put the slide back in now, and I can't remember why I put it back in. Right, I remember why I put it back in. So this is a reminder again of what I tried to really highlight at the beginning, which is that we are dealing now with an asymptomatic and minimally symptomatic population, right? We're going to do a screening test, we're going to identify those kids at risk, and we're going to bring them into a clinical care pathway, right? And so the initial part of that work has to be to try and stratify that risk, try and best understand who needs what kind of evaluation, what kind of intervention, and communication with the families through that is going to be key as well. So in terms of this collaboration, I've alluded to this, through the introduction, but to just lay it all out, The collaboration between NSO and the Infant Hearing Program to test newborn dry blood spot samples for hearing loss risk factors involves testing for congenital CMV, so CMV DNA and blood spots, and common mutations in these 3 genes. I had said 2 genes, but these 2 genes are actually very tightly linked. So I won't get into the genetics again, but common mutations in these genes. The rationale is to identify infants at risk for non-congenital permanent hearing loss and allow their appropriate surveillance to try and optimize the time at which their hearing loss is detected, to detect it as early as possible. Again, with the idea of offering the services and interventions that will help optimize their communication and cognitive and developmental outcomes. To introduce an etiologic focus to screen, I might say to strengthen the etiologic focus on screening. Often an audiological diagnosis might have been made, but a medical diagnosis of an underlying disease or condition might not have been. And for example, with CCMV, the characteristics and the natural history of the hearing loss may actually differ a little bit from other types of etiologies of permanent hearing loss. So introducing a bit more of that etiologic and medical diagnostic focus. And then also as a backup test for both false negatives. So if we have a kid who has 2 highly penetrant mutations in GJB2, where 99% of kids are congenitally deaf and they happen to fail their autoacoustic emissions, this does provide a safety net for those kids. But also for missed screens. We know that in the infant hearing program's hearing screening system, they have fewer kids who are screened than in the blood spot system. And this project will also allow reconciliation between the 2 to ensure that every child is offered hearing screening. And I think that's the last slide. Yeah. So in terms of the timeline, we've actually been in phase 1 since May of 2018. And phase 1 involved the reflexive testing of the newborn screening blood spot for CMV DNA whenever a baby did not pass their hearing screen. So if they did not pass their hearing screen, by definition, they've already been risk stratified into a higher risk category for having CCMV. And so those kids have been routinely tested across the province since sort of summer of 2018. So that's about 2% of kids were already being tested. And it was only for CCMV. We were not doing the genetic risk factors in that screen. In what we're talking about today is the phase 2, which is screening being universally offered. And this will be done by offering the expanded hearing screen, so offering the testing of the blood spot for CMV and the genetic risk factors at the time that the parents are approached for the actual physiologic hearing screening. So that could be at a phone call. Sometimes it's booked in the hospital nursery. Sometimes the screening is actually happening at the hospital nursery. But at the time that the parents are approached for the physiologic hearing screening, they will also be approached for whether they want the expanded hearing screen, which is the 2 blood spot tests that we're talking about. The rationale for that is, we often get the question, well, why not just do this routinely in all the, blood spots that are coming in? The rationale for the entire system and the entire project is around permanent hearing loss, and it's around optimizing the developmental outcomes by optimizing hearing and communication. If a parent declines hearing screening, it is then illogical to be testing their blood spot for genetic risk markers and CMV as a risk marker for permanent hearing loss. So the time for identification of whether or not to test the blood spot is at that time of offering the hearing screen. That then gets transmitted to NSO, and we already have the blood spot in hand, and it's that blood spot that is tested, right? So that's not an additional sample, but the approach and the consent has to be tied to the hearing. Right? And that's it. And I'm 3 minutes over. Not bad. No, thanks, Jess. Yeah. Okay, so do we want to do questions now, or do we want to? We can get like a couple questions about questions for that, just so that they. Okay, sounds good. So maybe why don't we start with the Zoom meeting people? Sitting on a lot of teleconferences, I often feel ignored. If is there anyone on the teleconference or on the Zoom meeting who has a question they want to ask?
Melanie, I could ask one quick question. Why do we don't have to get consent for the Ontario newborn screen in general, but you have to get consent to do CCMV? I just wonder why.
I think there's a few answers to that. One is that all the screening, whether it's the blood spot or the hearing screen, does happen by consent. In the blood spot, because it's been such a long-standing standard of practice, and the decline rate has been really so low that instead of introducing a consent form, the direction that was taken was to introduce a dissent form to document dissent when parents actually don't want to have screening done, but it is not mandatory. In the hearing screen, it's always been consented, and with a written consent that's been very lead agency specific. So each lead agency had their consent process, but their documentation has always been to document the consent as opposed to documenting the dissent. So Melanie, in the end, both are actually consented. It's and occasionally we do get parents who say, we didn't, no one told us about this, and the blood spot was taken, and we have concerns. Occasionally they've already signed the dissent form, so that's one of the reasons for having the dissent form. But that's usually an opportunity to reinforce that parents actually can decline. It's just almost none choose to.
Yeah, I guess I'm just thinking that they've consented to the blood spot. So theoretically, they've consented to the CCMV. It's just that the hearing program has to obtain a second consent, but it's a small issue, so it doesn't matter. I was just curious.
Yeah, and just to highlight the one point again is the rationale for testing for CCMV and for the genetic risk markers is really around the permanent hearing loss risk at this time, and that could change in the future. But if a parent were to decline the permanent hearing loss screening through the IHP, it would be illogical for them to choose one and not the other. And so it would be actually a difficulty in comprehension and communication. And so the main thing was to keep all the hearing associated risk factors and screening together, whereas the rare disease and blood spot targeted diseases were kept together in the other process.
Okay, makes sense.
Anyone else on the Zoom or phone? I also just realized I don't know where I'm supposed to be looking because whenever I look at the monitor, so I don't actually know where the camera is. Okay, anyone in the room? Yeah.
Do I do this? Okay, perfect. So I just had a question about the logistics for the genetic. So if there's a positive genetic result, so newborn screening, would it be newborn screening that's contacting the infant hearing program or contacting ENT at the tertiary center? Like, how is that exactly is that going to happen?
So I won't go too far into detail because we have monster algorithm flowcharts that I could show you. But I will say the key point becomes whether the kid's already been identified with a permanent hearing loss or not.
Yes.
Right, and that really becomes an important bifurcation in that pathway. If they have, they're already in the infant hearing program's ongoing care. They may have already been referred to an ENT, and so there's one set of referral pathways there. If they haven't been identified already, what they really need is a diagnostic audiology assessment if they haven't had that. And if they already have permanent hearing loss there, then again, they need to go into the ENT pathway. It's what happens when they have they don't have a permanent hearing loss yet, right? And so that one, that's where you may get some ENTs involved, you may get some clinical geneticists involved. And the main issue remains the ongoing diagnostic audiology surveillance.
And I guess the question is, but does that get automatically done through infant hearing or newborn screening, or is that the family doctor that's getting those results, or like, is that streamlined, like that's happening automatically?
Yeah, I think there is a chance that a primary care provider might be involved in that. The way we've chosen the mutations is that at the beginning, we're not anticipating, it's going to be a very exceptional circumstance when the child is not congenitally deaf, right? And so those we will deal with on a case-by-case basis, right? Some areas there's ENTs who have said they want to see those kids. Other areas there's ENTs, we only want to see kids if they have a permanent hearing loss. But the vast majority of the kids will be congenitally deaf, right? In the fall, we will start introducing one variant, which will be more associated with non-congenital permanent hearing loss. And part of the idea is to sort out exactly how that ENT care pathway goes. But in that case, I think there will be some who will go to ENT, some who may go to primary care, some who may go to genetics. And depending on the experience, this is one where this group of pediatricians may also, if interested, might be a logical, group. But I think the main issue in those kids is their hearing, right? So the emphasis is really on their audiological surveillance. All right, any other questions here? And if not, Ari is up.
Okay, so my task is to cover congenital CMV. I don't have any conflicts of interest. So this is what I'm going to cover. I'm going to cover epidemiology and transmission, clinical manifestations, some stuff around risk of disease progression, predictors of adverse outcome, issues around diagnosis and management, and then a little bit, I'll introduce kind of what Jess will talk about in a little more detail. So I was going to start with this, and we'll see if this works. The sound is not great. So I'm just going to show you a video about Francesca. Some of you may have seen this. So this was our first child that we saw at Sick Kids that was identified through the hearing screening program that then tested positive for CMV. And this is after she got her cochlear implant when they turned it on. So I just want you to see how she reacts when they turn it on and she hears for the first time. So I'm going to stop this halfway through.
So what we're going to do today is we're going to program Francesca's processor so that sound can go in and she can begin to hear. So this is the day we've been waiting for. We want to give her some sound gradually, and we're going to have you guys over the next couple of days increase the levels so that they become a little bit louder. But today, even though she's going to be having sound in both ears, the sound is going to be really, really soft, and we do that purposefully so that she's not overwhelmed or, too frightened to wear the processors.
She likes to run.
Okay, so that was 2. So that's good. She's happy.
To put sound on is unbelievable.
So I won't show the whole video because we don't have time, but anyway, she's done really well. So she's actually one of the youngest cochlear implants done as well. She was just less than 6 months of age, so quite exciting. So some key facts, just as a reminder. So congenital CMV is very common. In our setting, it's about 1 in 200 babies that have this. One thing that is not well recognized, and I'll come back to this a little bit later, is actually the majority of congenital CMV infection is in women who are immune. So it's second infections as opposed to primary infection. Overall, if you look at all congenital CMV babies, 1 in 5 of them will have sequelae over the long term, which means that 80% will not have any problems at all. It is the most common cause of acquired hearing loss, and there is evidence that early detection can improve outcome through treatment. Okay, so epidemiology and transmission. So seroprevalence does vary quite a lot around the world. We don't have data for a lot of countries. The ones that are shown are the ones in color that we do have data. And in general, for developed countries, the rates are around what they are in Canada, around 0.5 to 0.6%. You can see in some lower resource settings, the prevalence is higher. So the dark colors, India, Brazil, South Africa, et cetera, the prevalence is much, much higher in women of reproductive age. So I'll come back to that in a little bit in relation to non-primary infection. So for our setting, North American setting, most studies have shown a seroprevalence of somewhere between 50 and 80% in women of reproductive age. There aren't that many studies from Canada, but the ones that have been done, it's ballpark around 60%. It does vary a little bit, but it's ballpark around 60%. And you can see the factors that are associated with higher prevalence being foreign-born, more children in the household, more crowding, et cetera. Some risk factors for infection and pregnancy, exposure to young children is the classic, so toddler-age children, so childcare workers. Classic scenarios, it's a mom who's pregnant with her second child, the first child's in daycare, she catches it, and then the second child is the one that gets congenital CMV. If you look in daycares, I'll come back to this in the setting, but there's been lots of studies in daycares showing lots of kids shedding CMV. Selected features for primary CMV infection. So if you look at population-based studies in women that are seronegative to start with, the seroconversion rate during pregnancy is around 2 to 3%. Most of those women will not have any symptoms, so it's a minority that will have symptoms, and if they do have symptoms, it might be a mild febrile illness like a mono-like illness. But the key is that most will not have any symptoms. So this is an old study that Dr. Leaford-Jones did a little over 20 years ago. Quite a good study looking at lots of daycares, lots of children, and lots of daycare providers. And again, showing the urinary CMV secretion rate of around 17% in the children overall. You can see in the younger ones, it was around a fifth of them that were shedding at any given time. So daycares are full of CMV, no surprise, right? Shed in urine and shed in saliva. They looked at the daycare providers as well, and about, again, that number, 2/3 were seropositive at baseline. And when they looked at the ones that were negative at the beginning of the study, 1-year seroconversion rates in this population that's high risk was over 10%. So obviously higher than that rate of 2 to 3% in general because they're a high-risk group working with children. Okay, so let's say one of those daycare women, she's seronegative to start with, she catches the infection during pregnancy. What is the risk of transmitting CMV to the fetus? It depends on the timing of the infection and pregnancy. In general, it's like other congenital infections. If it's an early infection, the rate of transmission is lower. If it's late in pregnancy, the risk of transmission is higher. On average, if you look in most studies, in this particular study, the average overall was around 40%. If you look in the literature, you'll see this vary somewhere between 30 and 40% overall, okay? One of the reasons why the transmission rate is lower to begin with in the early parts of pregnancy is probably because the placenta is smaller, there's less permeability, whereas late in gestation, it's bigger and there's leaks and exchanges of blood, so that there's a higher risk of transmission. I should also point out here that in general, if you do transmit an infection early in the pregnancy, it's more likely to be severe, whereas if you transmit it late in gestation, it's more likely to be asymptomatic. Okay, so now I want to touch a little bit on, maybe you're familiar with this, but I find in general when I talk about congenital CMV, most people think, and lots of women physicians come and ask me, should I get tested for CMV because I'm pregnant or I want to become pregnant? And basically my answer is no, you shouldn't bother, okay? And the reason is your precaution should be the same. So these are data from Brazil, and there's lots of data from Brazil. The seroprevalence in women of reproductive age, and this is, I'm talking 18, so young women, is above 95%. So the vast majority of women are already seropositive, and yet their congenital CMV rate is higher than ours, it's 1%. So that's the first clue that it can't be that all of these women are having primary infection. You must be getting infections from non-primary infection. And in fact, in studies where they've looked at serology as a measure of this, they didn't have samples on everyone. You can see 44 of 87, but the ones that they did have, they showed that the vast majority had high IgG avidity. So high IgG avidity gives you a measure of this being a more remote infection as opposed to an acute infection. So most of these infections were in women who were already immune. So this is non-primary infections with different strains of CMV, okay? And in terms of the other point, and I'll come back to this a little bit later, and I won't go into the numbers specifically, but basically the rates of symptomatic disease and severity of disease is not impacted by whether you were previously immune or not. The outcome is the same, at least based on the data we have right now. And the data on that is a little bit limited, but that's what it shows. So this is a little bit of science. I know this is more of a practical conference, but I think it's interesting and worth kind of understanding. So why is this happening? So why, if you're immune, can you still catch CMV? And it comes down, at least this is probably one factor. So CMV is one of the largest viruses that infects humans. In fact, it's the largest, and it has a lot of genes and a lot of things that can help it propagate itself. So this is this class of genes, these US2 to 11 genes that interfere with cell expression of MHC1 molecules, which interact, if you remember, with T cells, okay? So there's been these animal studies in macaques where they've shown that primary CMV infection is not affected. So you take a CMV, you remove these genes from them, it won't affect their ability to infect for the first time. You'll still get that infection. But if you take these same CMV viruses and you try and infect a macaque that's seropositive, in the absence of those genes, it will not infect. But if they have those genes, because it can inhibit the function of the MHC, it can cause a secondary infection. So the bottom line from all of this is there's good evidence that secondary non-primary infection happens, that it's frequent, it's probably the cause of most congenital CMV, and there is a scientific basis for it, okay? So I put this slide up here for that reason. So my advice to women who are thinking about getting pregnant or early in their pregnancy, I don't think you should bother testing because the precautions you take should be exactly the same whether you're seronegative or seropositive. And this should be the advice we tell people. So, and there's been data, there are data on this, is simple things like not sharing food and drink with your toddler, not taking your toddler's pacifier, sticking it in your mouth, washing your hands after you change diapers. There's studies showing, longitudinal studies showing that women that do these simple precautions have a lower rate of seroconversion to CMV than if you don't do that. We're very bad as a healthcare system in general in providing women with these advice. I would say that almost every couple that comes in with a baby with CMV that I see, they mention that no one ever told them about what they can do to prevent CMV. So it's another one, we're talking about prevention, so this is something we could do a better job on. Okay, clinical manifestations. So as you all know the symptoms of congenital CMV. We're kind of familiar with the severe end of the spectrum. It's the baby that comes in that has microcephaly, and they have cerebral calcifications, and they have chorioretinitis, and they're deaf, and their outcome is abysmal. I guess my main message here is that that's a small minority of the congenital CMV cases that are symptomatic. Most of the babies that are symptomatic with congenital CMV have much milder symptoms. They might have just a petechial rash with some thrombocytopenia and have completely normal growth parameters. They might have a little bit of liver dysfunction and nothing else, or they might have a combination of things. The bottom line, it's a spectrum, and most of the symptomatic babies are on the milder end to begin with as opposed to the severe end. Okay? Just some examples. So this is a typical baby with a petechial rash and some thrombocytopenia, completely normal growth parameters and nothing else. This is perhaps the most common manifestation we would see in a newborn that's a symptomatic baby. Chorioretinitis, we always look for it, but it's probably one of the least common manifestations. I would say I have maybe 2 babies in our clinic that have had some of this, but it's not that common. Neuroimaging, again, you're familiar with, there's a lot of things you can see on neuroimaging or have intracranially. So calcifications is the most common, classically periventricular. You can have ventriculomegaly. You can have microcephaly with cerebral volume loss. The severe end of the spectrum with very early infections, you can have migration abnormalities like lissencephaly, et cetera. Common things that you see late are white matter changes, like in older children. And then an important one to mention because it's so common and of questionable or we don't really know what its significance is, lenticular striate vasculopathy. So this is just some calcifications you see in the thalamic vessels. It's not specific to congenital CMV, but it is a common finding that you see in congenital CMV. So this is just some examples. This is the severe end of the spectrum, the calcifications that are classically periventricular. You can see also there's ventriculomegaly here, and just another one over here. And this is the lenticular striate vasculopathy I mentioned. So very often this is an isolated finding, and otherwise the ultrasound looks normal. So whether we would treat a baby with this, these are where things are controversial and nobody really knows. This is some adhesions that you see related to CMV, and this is the worst end of the spectrum where you have a smooth brain, so lissencephaly with some calcifications and really cerebral atrophy, terrible outcome. Okay, so I talked about symptomatic congenital CMV here, which remember is a minority. It's about 10 to 15% of the cases. I'll come back to that in a second. So how good are we at making a diagnosis in babies that present with symptoms? So these are data from two sources. One is one of the Canadian Perinatal Surveillance Program survey things that they do, and the second is data from BC. So the first one, the CPSP one, so this is Wendy Vowdery from Alberta did this study. So they found 49 cases of symptomatic disease based on this reporting, which translates to a rate of around 4.5 per 100,000, when the expected number based on the population level was somewhere between 26 and 90 per 100,000. Now, you can make an argument, well, it's CPSP, people are just not answering their surveys, and that may be part of the explanation, but the feeling in the article that this is an 80% underreporting rate, and that they think that based on evidence from CPSP, this is this is not as good as they expect from most of these surveys. So they felt that this means we're missing symptomatic congenital CMV cases. In other words, babies have symptoms and they're not being tested for it. Okay? The data from BC are a little bit more robust in my opinion, and that's because BC has a centralized lab system. So basically the BC CDC is the one that does all of the CMV testing. So they took all of their CMV tests that were done on babies between June 2006 and 2014, and they identified only 14 cases of CMV in that cohort. So this is based on babies that had symptoms, right? So that's why the test would have been sent, again, for a rate of 4.2. And their estimates based on 0.5% prevalence and 10% being symptomatic suggest that there should be 50. So again, strong evidence that in fact, on a population level as healthcare providers, even in babies that have symptoms, we're most often not thinking about CMV and not testing for CMV. So it's not just the asymptomatics that we're missing the symptomatics as well. Okay, so risks. So this is kind of a busy slide, but I just want to take you through like 1,000 babies with congenital CMV infection. Somewhere between 10 and 15% of them will be symptomatic at birth, meaning they have manifestations that you can see. They've got microcephaly, they've got a rash, they've got a hepatomegaly, something like that. The risk of sequelae in that group, on average, is about 50%, somewhere between 40 and 60%, that they will go on and have permanent sequelae, developmental delay, hearing loss, etc. If they're asymptomatic, which is the majority, around 10 to 15% of them will go on and develop sequelae, most commonly hearing loss. Okay? Overall, as I said, if you take all comers, about 1/5 of babies with congenital CMV will end up with some kind of sequelae, the most common being hearing loss. And 2/3 of those with sequelae come from the symptomatic group, just because there are many more of them. Right? So if you take all comers, most of the hearing loss is going to be from the asymptomatic group. Okay, and this is just looking slightly more closely at that. So the numbers are a little bit small, even though it's a pooling of 10 studies. So there were only 19 symptomatic, so you have to kind of take this with a little bit of a grain of salt. But just again to show you around 60% with the deficit, the most common being neurocognitive delay, isolated hearing, you can see in 16%. But the main point I wanted to make from this slide is really the asymptomatic group. So by far the most important outcome long-term when the asymptomatic group is hearing impairment. If you look at the rate of isolated neurocognitive or motor deficits of 3%, It's a little bit above what you expect in the population as a whole, but not by much. So really, it's the hearing loss that is the key thing amongst the asymptomatic group. Okay? Now, if you look a little more closely, this is a really nice study that pooled data from many, many studies looking specifically at hearing loss. And if you wanted to remember one number, so if you take any hearing loss in symptomatics, it's around 1/3 of them will develop hearing loss. In the asymptomatic group, it's about 1 in 10. So 10% versus 1/3, okay? The ones that are symptomatic at birth, and this is kind of intuitive, it's more likely to be bilateral compared to the asymptomatics, and it's more likely to be bilateral severe to profound in the symptomatics, okay? Again, this is a busy slide. I probably won't belabor it, but basically this is pooling the data from the outcome by type of maternal infection, primary versus non-primary infection. And the bottom line, just to reiterate what I said before, is that in the non-primary infection group, so this is basically symptomatic, you can see the symptomatic rate in primary versus non-primary is basically the same. And when it comes to moderate to severe impairment, the rate was actually higher in the non-primary, but look at the numbers here. But bottom line is with non-primary infection, at least with the data we have right now, the outcome is just as bad as with primary infection, okay? What about predictors of adverse outcomes? So some of this also kind of makes logical sense. If you got microcephaly at birth, you've got a high risk of having an adverse outcome. If you've got brain CT abnormalities, that would also be the same. I think one thing about the imaging abnormalities, if you have normal imaging, it's actually a very good sign that you will do well, except perhaps for the hearing. And then one thing about disseminated disease, so the kids that have hepatosplenomegaly, IUGR, and petechiae, they have a higher risk of going on to develop hearing loss compared to babies that are asymptomatic. And this is just a study looking at CT scans, so going from relatively mild to relatively severe. They graded it 1, 2 to 3, and they looked at IQs, motor deficits, and hearing loss, and kind of as you'd anticipate, the ones that have worse imaging have a much higher risk of having neurocognitive delay, a much higher risk of having motor disability, and a much higher risk of having hearing loss. Kind of makes sense, right? Okay. Now for the asymptomatics, and this varies from study to study, and the bottom line for the asymptomatics is we do not have a good predictor for who is going to go on and develop hearing loss or not. In this particular study, and I think this pans out in the studies that are available so far, if your blood PCR is negative, your risk is lower than if it's detectable. But we can't really give a cutoff of if it's this or that. You can really say what the risk is. We can't on an individual basis do that, but it seems that if you have a high viral load in blood, your risk of going on to develop hearing loss is higher. Okay? Okay, diagnosis, just as a reminder, the way to make the final diagnosis is basically urine or saliva in the first 3 weeks of life. If you do it beyond 3 weeks of life, you don't know if it was congenital or postnatally acquired. So that's why that's important to get it in the first couple of weeks. Remember that if you're using saliva, this varies from center to center. If the baby is being breastfed and you take the sample right after, it can be falsely positive. So you have to kind of take that into account in terms of your timing. I would not use serology. We generally don't rely on it. And then PCR, I mean, now we're using this as a routine screen, but retrospectively, you can use this to make a diagnosis. So, for example, if I get a referral from ENT of a child who's got hearing loss detected at 4 years of age, and we don't know the cause, then you can go back to the birth-dried blood spot and test it. The sensitivity is limited, but if it's positive, it gives you a diagnosis. A negative doesn't tell you it's not CMV, but a positive tells you it is. They store those in Ottawa, I think going back to, right. So we've had occasional cases of older kids. Those are the ones we can't find them. They used to be at PHL and we can't find those. Yeah. They're just, we can't always find them though. It's a bit of, yeah, we've tried. Okay. Okay. Okay, so you get a baby who has targeted or has been labeled as having congenital CMV based on the dried blood spot. So what would we do? I would confirm the diagnosis with a urine or saliva. You do PCR. The standard investigations that I generally do is a CBC, liver function test, and creatinine. I like to do quantitative CMV PCR for two reasons. One, because it does have some utility in terms of predicting outcome. And two, if I'm going to treat, I like to follow it to make sure I'm suppressing. They obviously need their audiologic follow-up, they need eye exams, and they need neuroimaging. Main message for neuroimaging, I think ultrasound is fine for the vast majority. I only rarely go on to do an MRI, and I can't even remember the last time I did a CT, okay? So who should be referred to ID in the context of this? We can debate this a little bit later when Jess talks, but these are my thoughts on this, given that it's kind of a program that we want to evaluate. I think if the babies are symptomatic, whatever those symptoms may be, would be a reason to send to ID. If they've got lab abnormalities, like hepatitis, for example, or they have a very high CMV PCR in blood, or obviously if they have hearing impairment, eye disease, or neuroimaging abnormalities. There are a lot of nuances in terms of who we would treat. There's the ones that are obvious with the microcephaly and calcifications, but many of the kids are kind of the in-between ones, where the decisions are kind of, well, you know, a little bit of IUGR, a little bit of low platelets. Do you treat them? Do you not treat them? And there's some nuance here, and really nobody knows whether they will benefit or not. So why CID? So that we can make decisions on treatment. So what's available for treatment? Really what we're talking is ganciclovir and valganciclovir. The only reason I would nowadays use ganciclovir is if they're in the NICU and they're NPO. Otherwise, basically Valgan is well studied. That's what I would use. The other drugs are kind of, I put them in brackets because we've never used them to date. So the potential benefits, and I'll get into the studies, is improved hearing developmental outcomes. Potential harms, the medications can suppress the bone marrow. That's the most important one. Neutropenia is not uncommon. And then there's some unproven animal-based concerns around gonadal dysgenesis and carcinogenicity that I always mention, but with the caveat that it's animal study-based and these things have not been observed in humans to date. So this is the key study. So this was a study published in 2015 in New England Journal of Medicine comparing 6 weeks, because there had been an older study showing that ganciclovir for 6 weeks was better than placebo. So this was comparing 6 weeks to 6 months of oral valganciclovir. These were the eligibility criteria. They had to be symptomatic. I think what doesn't come through in the article is if you talk to the authors, most of the children in this study actually had towards the more severe end of the spectrum. So you didn't have babies with isolated thrombocytopenia. It was always more severe than that. And their endpoints were really primarily related to hearing and neurocognition. So there were no differences in the primary endpoint of hearing, best ear hearing at 6 months of life. There were differences in outcome in the longer treatment, with longer treatment showing benefit for hearing at 12 and 24 months. I should point out the p-values are borderline, but there was a benefit. And if you look at neurocognition at 2 years, they had better Bailey scores and higher scores in other domains as well. So there is evidence for benefit. It's not massive, but there is evidence for it. And in terms of toxicity, they didn't observe differences between the two groups in terms of neutropenia, but I've seen it. So if you look, so subsequent to that, there's a nice, this is a good paper to have. There's a consensus statement that we weren't involved with, but a lot of the experts around the world were. And this is kind of how they broke this down. They said that treatment is recommended for neonates with moderate to severe symptomatic disease, should be started in the neonatal period. Oral Valgan is preferred and the duration is 6 months, and that's all based on that New England paper. And then they had some recommendations on the monitoring. Initially, you have to poke quite a bit. The first month to 2 months, it would be every week to make sure there's no neutropenia or other bone marrow suppression effects. And if there is, you might have to interrupt therapy. And then as they get older, you can space it out. So, and then in terms of, so I mentioned moderate to severe. So this is kind of what they mean. So multiple manifestations, including IUGR, hepatosplenomegaly, petechiae, thrombocytopenia, hepatitis, or the more severe end of the spectrum, CNS disease, hearing loss, etc. And then they had the mildly symptomatic, and they're somewhat vague about this, so it's 1 or 2 transient symptoms in isolation. So for example, that might be thrombocytopenia with an elevated ALT or something like that. So would you treat in this, they're kind of calling that mildly symptomatic. They also broke down these, the asymptomatics into asymptomatics with isolated hearing loss and asymptomatics with nothing. Remember, this is going to be the biggest group by far. Okay? So there's controversy here in this one as well, whether you should treat a baby with isolated hearing loss or not. Okay? We've tended to treat them, but not everybody does that. Okay? So what is the role of treatment in asymptomatics or mildly symptomatics is one controversy. The current consensus recommendation is not to treat these, although many clinicians, as I mentioned, will treat isolated hearing loss, unless it's bilateral and profound. If it's bilateral and they have no residual hearing, there's no point. But if they have like unilateral or partial hearing loss, then a lot of us would treat those. The treatment duration, the current suggestion is 6 months based on that study. There are some case series of longer treatment, but the data is a lot softer. I personally am more aggressive than most of the people that I know in this field. So I have treated people for a full year if they're on the more severe end of the spectrum. If they tolerate their Valgan to 6 months, you're not going to have any problem after that. It tends to be earlier on that you see the problems. And then so this is the other one, is treatment initiation beyond the neonatal period. So let's say in the first phase of this, some of those kids were picked up late. So they failed their hearing at, let's say, 2 months, and then they got their dry blood spots. So they end up getting to me at 3 months. Do I treat? Do I not treat? It becomes controversial, and it depends on the case. Because remember, the study itself was initiation during the neonatal period. So we don't have good data for if you start later. Okay, and then follow-up. So this is based on the consensus. So, and we probably will not follow this exactly, so I should mention that. So they suggested at 6-month intervals for the hearing for the first 3 years, and then annually until they're adults. Eye exam, they need a first eye exam, and then it depends what the eye doc wants. And then they suggested formal neuropsych developmental assessment on a case-by-case basis. So again, we're not going to follow exactly these recommendations, and we'll have to decide we'll have to see what we decide. So I'll just finish with NSO. So initial assessment, so physical exam looking for the clinical manifestations, and then the baseline workup. This is what I think you should do. You should confirm the diagnosis with urine or saliva, and then do the things that I mentioned before. The audiology will kind of happen automatically, so you don't need to organize that, but the other ones will kind of involve you guys. So the blood work, organizing ophthalmology, and organizing neuroimaging. And as I mentioned before, head ultrasound is usually all you need. The only caveat to this is I want you to feel comfortable that you trust the people that are doing your ultrasounds, because we know that that's operator dependent. But in principle, if you feel they're good, then that's good. This is also, take this with a grain of salt. I was told I shouldn't show this, so I'm in trouble already. So in terms of the audiologic follow-up, this has not been finalized in terms of what exactly we're going to do, but tentatively this is what people have thought. So you've had your initial assessment, whenever that was, let's say at 1 or 2 months. Assuming it's normal, then you would have a follow-up at 10 to 12 months, 15 to 18 months, and then 3 to 5, and I don't know what will happen after that. So, but again, this is all kind of in flux at this point. Likewise, Jess will go into this in more detail, but this is kind of what has been mentioned, is developmental assessments more frequently in the first couple of years of life and then being spaced out over time. I think the specifics kind of we can work out. So for the symptomatics or abnormalities on baseline blood work, I think this is where the reason I put urgent referral to ID is because we need to make decisions. Is this a child we're going to treat or not treat? Because it's a whole different follow-up strategy if we choose to treat them. And again, just to reiterate, a lot of the cases are not clear-cut. So the mild to moderate, they've got isolated petechiae, they might have IUGR that's borderline, they might have a little bit of hepatitis. A lot of these cases are kind of in between. So that's why, I mean, there's a lot of nuance in it. And then the toxicities we've kind of talked about already. These are some references I would suggest. So this is the consensus statement I just mentioned. Even though we don't agree with everything in there, it's a good document to have because it summarizes the literature really well. It talks about from pregnancy all the way through. This is a European statement, which I think is a nice counterbalance because they don't say exactly the same things as the other consensus statement. This is sort of the Canadian group. We published, this is a brief kind of general discussion of congenital CMV. And lastly, the New England paper on the valganciclovir is an important one to know about. So those are the four that I would suggest familiarizing yourself with. And that's it. We're in the process of stopping CMV. Vaccines, by the way, we're a long way off. There's been some vaccine trials, but the problem is if you think naturally, if even your own immune system can't prevent infection with a new strain, it's going to be pretty difficult to prevent it with vaccination. Okay, so that's my part. Do we do questions here too, or? Okay. Should I start from any questions from the people on the line?
Hi.
Okay. Oh, yeah.
Hi, this is Panita. I just had, just to clarify then, so for now the plan seems to be that for kids who have isolated hearing loss and are otherwise asymptomatic with normal labs, we should still plan to refer to ID for that decision of whether they will be treated or not.
I think so, yeah. I mean, obviously they need to see ENT, but a lot of us, so two things. One, most of us, I think I can speak for CHIO as well. We've tended to treat them if they've had isolated hearing loss. If they get picked up later, I think the later it is, so let's say just for sake of argument, they're 3 months when I get to them, then it becomes a little more soft and we may join into a US trial on this. That's kind of in the works. But the bottom line, especially if they're closer to the neonatal period, if I get a kid who's got partial hearing loss in one ear and the other side is normal, I'm treating that baby for sure. Because, I mean, the logic behind that for me, and I actually spoke to several of the authors of the New England paper that agree with me on this. The main benefit of the treatment was with respect to hearing and speech development. So it didn't make sense to me that you wouldn't treat a baby that had isolated hearing loss. So that's kind of where we're coming from. The only downside to that is we don't have a lot of evidence for that particular scenario.
Right, okay. But the chance also that it could be progressive and so on kind of factors into it.
Yeah, exactly.
Okay, all right, thank you.
Any other questions online? Sorry.
Sorry, it's just Brandon, just practically, I think the question also was, should those babies be referred to ID? And I think the answer is yes, right?
Right.
So I was just going to ask, just practically to follow up on that question, if these babies are screening or having a finding of hearing loss, that would actually be done by the infant hearing program, and then we'll be getting these infants who have then had a positive CMV spot. So would the infant hearing program have already referred to ID, or we'll wait for those kids to come to us, we'll do our exam, get all our other investigations, and then take it all together and refer to ID? Like, is there some process to send directly to ID initially, or then we'll do it?
Yeah, so it's going to be interesting to see how this happens because we're likely to get the CMV result before you've had your confirmatory hearing assessment. So you might have failed your quick newborn screen, but you haven't had your real test. So you're likely to have the PCR result before that happens.
Okay.
But I guess as part of doing your workup anyway, and then the hearing will come into it, and then you'll know, yeah.
My other question was actually, I had a different question prior. So we're planning to work locally with our radiologists at North York, but I was wondering if we could have some document to take to them and say, listen, these are the findings that we'll be looking for. Do you feel confident that you can identify these. So I was wondering if we could have some sort of summary document of what exactly we need to ask our radiologists if they can do, because they definitely do all of our, we have a level, 2C NICU, so they are comfortable with all of those findings, but we need to now ask them if they can, if they want these at sick kids or they want them there. And so just wondering.
Sure. I mean, I guess you could ask them generically, are you comfortable with congenital CMV, but we could provide a list. I think one of the softer things would be the lenticular striate vasculopathy. I think the calcifications would be that would be kind of obvious, but some of the softer ones, yeah. Yep.
Hi. Regarding the reporting time for the CMV PCR, so will it take as long as the 2 weeks that is usually for the newborn screen, or will it take less time, and we will know anytime faster the results to proceed forward into more investigations or else?
Right. So you guys are probably better situated to answer that than me, but my understanding is it's supposed to be pretty quick.
Yeah, so I think the difference is that the probably delay in time, or the step, that the rate limiting step will probably be the consent process, because the CMV result should be processed as part of the regular newborn screen on that same dry blood spot, and I'll go into that a little bit more during the clinical care pathway talk. But so by the time the consent from the screener reaches NSO, the turnaround time should be 24 to 48 hours. Yeah, it is pretty fast, because the results should be there. It's not like it's reprocessing and hunting down the dry blood spot to then perform a new test on it. It's just a matter of more releasing the results that have been done kind of in the background, if parents are consenting to that test. If I can just touch on the other thing, a technicality, audiology can't make a medical referral. So in different places, depending, so I don't believe it's the same in all of the Toronto region. I know in Ottawa, because it just happens that our IHP and audiology is all centralized at CHEO, and they're like bumper to bumper with the ENTs. They've worked it out that they can make a referral to ENT, but that is not the general practice. And so, like Ari mentioned, there will be probably having the result before that diagnostic audiology piece is available. But I think we, for the most part, think it will be part of the complete assessment that would happen with the pediatrician as part of the medical referral. In that case, you might, having that there is that definite symptom of CMV, might trigger the referral to ID sooner, as opposed to waiting for all the rest of the results to come back. And I think that also might be the fail-safe, or the other kind of catching piece of that is, I think probably Andrea is going to be aware of the babies as they screen, sort of tracking through them as they go through the pathway, because it will be kind of a parallel pathway within the infant hearing program, and then the more medical pathway with all of you. But hope that answers.
Yep.
So when there is a positive finding, who will be notified immediately? Would it be the NICU? Would be the family? Would be the hospital where the sample was taken from? Who will be the first one?
So that's what I'm going to go through in the next talk, kind of walk through all that piece. So I'm glad you've kind of lit the stage for that one. I don't know if there's any other questions before we kind of go to that piece that people have for about the clinical care for Ari.
There's a bit of a delay. I just want to make sure, in terms of the referral to ID, is it sufficient, in a kid that we're pretty comfortable is healthy, or has more minor symptoms, to make a referral through EPIC with an urgent heading, or would you like us to call, just from a logistics point of view, to make the referral to ID?
I think either way, I'm pretty quick to jump on these. Okay. So at least from my perspective, whatever works for you. We see them pretty quickly. The other thing I should mention, by the way, before I forget, is, and this is just based on the experience of the last year, is let's say you have an asymptomatic one and your workup is negative. Some of these parents are extremely anxious. The moment they get the result beyond Google, I mean, even when I've seen them within 24 hours, they're coming like in tears, they're coming in pieces. So if there's a particular family that you feel would benefit from a one-time CID for some extra counseling, that's another reason to refer. It's kind of one of those, it sort of depends on what you feel comfortable with and what you think about the family. But that, just from the last year, that's been my experience, that some of these families come very stressed.
Oh, so I was just surprised that the sensitivity for the blood spot PCR is only about 85%, because right now, at our institute, I'm sure everyone's institution, like we're still screening, we're sending urine CMV for children who have microcephaly or IGR or whatnot. So I guess I was thinking that once this started, we wouldn't be doing that anymore. But I guess if 15% of them aren't going to be picked up, that we should still think about it.
Yes, absolutely. If you have a clinical reason, I would do urine or saliva. Their sensitivity is much better than the dry blood spot. I'm actually not convinced that it's 85% either. I think if you look in the studies, it's varied from as low as a little around a third in one of the largest studies published in JAMA to around 90%. So the meta-analysis suggested 85. That's where that number comes from. But I think it depends on the PCR, and I don't know that we know for sure in real life setting what the sensitivity of our assay will be. We have a sense that it's around 80 to 85% based on some preliminary analysis, but we don't know for sure. So bottom line, if you have a clinical case that you think is, you do urine or saliva. By the way, just getting into so there's would debate. Well, why not use this? Why not use urine or saliva as your screen? And maybe that's the future. But the reason to use the dry blood spot is because it's already being collected and the infrastructure is there so that we can do it. But that is something that may change in the future.
Okay, so thanks for sticking with it, and especially for those of you on Zoom or on the phone. The last section before we get into more of a discussion for each place and can ask some general questions. Hopefully it's just to go over the positive pathway. So what happens exactly, like was brought up, when a child is identified as being CMV positive on the blood spot. Hopefully this will kind of pave the road for about 85 to 90% of those cases, and we can talk about the one-offs after. So I have nothing to disclose. No one's giving me money or anything else like that. Things that we will go over is really what we call the retrieval and referral. So retrieval because this baby is being identified as part of a screening program and they are not necessarily in a clinical care setting. So they're being retrieved and brought back into a clinical care scenario. Talking again about, or reviewing again, the initial pediatric assessment, which really Ari went through, indications and reasons to refer to ID, a little bit around the treatment decision-making, the developmental surveillance, the audiology assessment and surveillance piece, and then a bit more about the reporting of outcomes. So some of this is going to be repetition to what we just heard, but I always think that's helpful to bring things home because this is what you guys want to make sure that is being done. So as was mentioned, and I think we've kind of covered this now through the two talks, this is a joint venture that's happening to expand the hearing screening by looking for additional risk factors on the blood spot and then also expanding from the hearing piece of it to an overall medical workup. We know that it's going to be both the genetic risk factors, which will be part of a different pathway, but some of your kids, because CMV is positive, could also have one of the genetic risk factors. But the majority of this is really about CMV. And the what will happen, as I think we've mentioned, the dry blood spot gets taken at birth, as it regularly does at 24 to 48 hours of life. It will get processed for the regular testing that is done as part of screening for the 29 or so diseases that are on the dry blood spot. At the time that the child is either in hospital getting their infant hearing screening done, part of the IHP, which happens depending upon the hospital. Some it's like up to 95%, other hospitals it's happening a little less. they will be consented for the expanded screening for the genetic markers and for CMV on the dry blood spot. In some other cases, for screens that are done in the community or perhaps a place where screening isn't done on the weekend, the children, the parents will have a phone call to book that appointment in the community. And when that booking is being made, there will be a request for consent or discussion of consent at that time. So even if the child doesn't make it to all the way, they don't have to make it all the way to that hearing screening appointment in the community before consent is obtained. Once consent is obtained, it's a verbal consent that is documented in a written way. It gets transmitted to NSO, and at that time, that's when the 24 to 48 turnaround time happens to release the result of CMV detected or not detected on the blood spot. This is then the complicated, if you really like to follow pathways and want to choose your own adventure, you can go, you can look all the way through this, but this is what we'll really talk about, and starting right at the top, what happens when that CMV is detected. So the disclosure of the results, so will be happening from the sick kids nurse practitioner who is based at within the ID clinic at Sick Kids, and that's Andrea, who's right there. And so Andrea will every morning be getting results of all these screen positives in the in the laboratory information system. At that point, she will then be reaching out to the families and giving them a call to disclose the results of the test. You know, which good on her. She may have some very surprised who may or may not remember to consenting to this. And in other cases, this may be children who appear, or most of, sorry, not maybe, the majority of the children will be kids that are at home who are very healthy and well. And then they will have, not even in some cases, have had their hearing screening done. After the disclosure to the family, there will be a medical referral that will be triggered from NSO, from either Pranish or myself, that will then go out to you guys in the community who is where this child lives or where it seems to be sort of appropriate from that to. So even if the kid's born downtown, maybe they're from the north, and that makes more sense for where the child can be seen and have their full-on assessment. That fax, or however it's agreed, probably it'll be a fax in most cases, but that's one of the details that Andrea will be connecting with you guys about to find out the best way to communicate and initiate that referral, because most of the time, although not an emergency, as I mentioned, there is a reason to be doing this in a timely manner. And so you guys will receive the medical referral, which will allow you to bill as a medical consult. And then the child will follow through the workup that has been talked about, and then we'll go over again. The parallel pathway will be the result of the CMV positive screen will then be reported to the IHP, and that is not something that the pediatricians in the community are expected to do. So that's going to happen again at the same time, and the child will then be advanced, if they have not already been, to have a diagnostic audiology assessment. So they won't go through the screening bit, they will have a full, thorough assessment for their hearing. And those results will may or may not be available at the time the child has seen you already, or maybe, you know, a couple days before, maybe a couple days after, maybe right at the same time. When, so how that kind of looks a little bit over the province, just to let you guys know the sort of landscape of things. For all the infectious diseases and NSO referral centers, or where the NPs will, for the most part, be based, are where the red circles are. I will say and this is traditionally where a lot of screen positives get referred to, who are born in Ontario, to one of the sort of pediatric academic health sciences center. In the Northwest, sometimes it makes more sense for those children to go to Winnipeg, so sometimes they're seen there. But these kids are, the referrals are often seen there, which is going to be some overlap, but a little bit different than what's happening in the CMV program. And just to kind of compare where all the IHP 12 lead agencies are laid out, they are, again, where all the same pediatric centers are, as well as additional sites, and some of those will feed into the various the various academic health sciences center. So as you can see, I think Peterborough also feeds into Toronto, and then there are, I think, three lead agencies within the Toronto area that feed into that are within those. So once those, so that's kind of traditionally how the layout has been for kids who are being seen through the NSO program for positive referrals. Again, it will be a little bit of an overlap. So they may have their IHP being done in their closer to their home setting, but they may they may have their hearing being done closer to their home, but have their need, if they need to see ID, come a little bit further in. The initial pediatric assessment, as was kind of outlined on the NSO website, and many of you may have received this handout, is just what Ari had mentioned before. So really the confirmation of the CMV infection, which for the most part, I think people are doing by urine. Yes, saliva is also there. I don't know, to be honest, how many places are accepting saliva as a screen that have kind of done the QA testing for that. And again, it is subject to some false positives. Then there will be the physical exam, which is again why we want pediatricians who are seeing a lot of these babies to develop some expertise in seeing some of the children who may just have subtle and kind of non-specific signs and otherwise look well to a lot of people. The head ultrasound, the laboratory blood work, and then the ophthalmology exam. We have, here just to show you, had some wonderful support from Public Health Ontario and from the microbiologist there that has really made a pre-filled form that should be final and available to you guys in the next, I think, couple weeks or something, we said, like by the time the program starts, that in some cases, for those of you using an EMR, should be able to incorporate into that. And it will just be sort of well laid out that this is going to be CMV PCR testing in the urine so that it can get streamlined to right to where it needs to go. The point again being that there needs to be this assessment done really prior to the 30-day mark so that children can be considered for treatment if necessary. And what we're asking, in as much as is possible, and realizing it won't always be, but to try and coordinate as many of those investigations as possible for families that are coming in. We realize in many places this is an ask on your radiology department. This is, many of you have busy clinics that are trying to fit these children in, but if they can, because the anxiety and everything that comes with the uncertainty of what CMV may mean for their babies, a lot of parents are quite anxious, and if we can get as much of the workup and save multiple trips, that would be a definite goal. So in terms of who then, once you have this, done this complete workup, should be sent to CID, really are symptoms of congenital CMV, and I would say regardless of age, for the reasons that Ari had spoken to already. I think there's indications to have a conversation with the family and to let them know a little bit more what to expect, and they may, after some discussion, have there may be a role for starting antiviral treatment at that time. So there will be very obvious things for microcephalic children, kids that have very obvious glaring cerebral calcifications on their head ultrasound, those that have retinitis. Those might be kind of no-brainers as to refer to ID. In coming back to some of those like nuanced, sort of not as clear-cut ones, those still would merit a referral to ID. Can tell you the lot of time that we've talked in Ottawa to some of the pediatricians that we hear, how many babies do you think we get that are IUGR, and how many babies do you think that we have that are thrombocytopenic? You know, not all of them have CMV. No, but probably more of them do have CMV than we actually know about. because we're not that great at identifying who the symptomatics are. And so even though the evidence isn't as clear cut in terms of some of these indications, there are a lot of us that may treat or may at least have a discussion with the parents about treatment. And again, isolated hearing loss is definitely something to be referring. I would say, I think Ottawa and Toronto, we definitely tend to treat children who don't have any other symptoms but do have hearing loss, as for the reasons that I already mentioned. But that isn't uniform, and a lot of people are still waiting to have the clear-cut evidence for, and there are a lot of trials that are going on for that. In those cases, a lot of it comes down to a discussion that will happen between the ID physician and the families to make them understand where the evidence is and isn't, and understand what the need for ongoing follow-up and monitoring through treatment might be. And that some parents have been turned off by that, and some parents have still felt the strong desire to go forward in the absence of really crystal clear information regarding their specific child. So again, whether or not symptomatic disease is clear, I know that in Toronto they would be happy to get these referrals, especially as the program's going on. As I already mentioned, any need for further counseling or the parent requests saying, oh, I just really want to talk to somebody else about this. And I would say, generally speaking, not all, but if there are children who are admitted to the NICU where there is where they are thought to be quite symptomatic, I think that would be a very appropriate phone call to be having with ID, just to make sure that the treatment is indicated and what might be kind of the other pieces of the conversation to have. I think we're expecting to see a little bit of change in time as the program goes forward in terms of the number of referrals that are happening at the beginning, and maybe as all of you feel more comfortable sort of what the counseling advice will be for patients that are asymptomatic, but parents have more questions, then maybe those will stay more in the community, but not at the gate. Again, I think we've gone through a lot of this, but a lot of what the even some of the people who have been treating CMV for a long time have cautioned against in terms of treating without clear indications or treating the isolated hearing loss is the discussion around what are some of the long-term side effects that could be put out, even if they haven't played out, that we don't, the evidence isn't there, and so that warrants a discussion with parents. And then also that they are knowledgeable that this is going to require monitoring, at the beginning every week, and then kind of going forward for blood work. There should be guidelines that are available to you from the Ontario ID Working Group that is chaired by Ari and then Jason Brophy at CHIO. With that, they're in near final stages, I would say. But I think that once that document is finalized, it will really lay out clearly and should line up nicely with a lot of the treatment recommendations and guidelines in the consensus statements that Ari had referred you to, that there will be indications for treatment and for referrals, as well as definitions for things of what is counted as thrombocytopenia, what growth charts that we are using to sort of measure for IUGR and for microcephaly, et cetera, just to be consistent so that everyone is feeling that they're on the same page and doing what their neighboring city is doing. And then really coming back to that whole discussion about isolated hearing loss and the age of treatment. There are trials that are going on, and I think in the years to come we will have more information out there. But a lot of the time now it's experience-based that's guiding those decisions and recommendations to parents. We'll say that and there may be some families for folks that are from a little bit further who fall into the Toronto catchment, but who are following families that don't, where it's too much to drive in every day. And so just to make you aware that in consultation with ID for those kids that are on treatment, again, I don't know exactly how it's working in Toronto, but I imagine there will be some that are kind of co-managed. but there may be need to hold some of these medications based on the neutropenia and then to recheck it again and start it. As I already mentioned, it usually happens at the beginning if it's going to happen at all, or sometimes we see it when kids get a viral URI. And for you guys to know if families are coming in to see you while they are on treatment, I think we've noticed that there tends to be a little bit of GI upset with Valgan. I don't know if Ari has seen that as well, but Jason and I used to explain it away by like, oh, all babies reflux and oh, something else. And then they stop when they're at the end of their 6 months and it all kind of goes away. So just to be aware that in some babies, they do experience that. In terms of the developmental surveillance, so again, a key point for those of you that are here, it really is looking to do 3 developmental screens in the first and second years of life. The initial email or the initial documentation that went out was really asking for 3 developmental screens a year, up to 6 years. And we put that out there because there is a billing code that can be used for children that are the K119 that can be used for children who are at risk for developmental, poor outcomes. And so that was something that could be used, but we have heard back from a lot of people about that's just not practically what they do for other children in their practice who are at risk for developmental delays going forward. And certainly, I guess the messaging would be that really these children should be followed like any other child at risk. And, there is no absolute mandate that they have to be seen at exactly this age for each one, but the general recommendations that I think we will be looking for going forward with the program will be the 3 developmental screens in years 1 and 2, followed by annual screens later. And certainly if children do flag as having any difficulties or delays, that they should be getting a formal developmental assessment. Hopefully many of you have been asked if you have the ASQ3, that was the, and the toolkit, that was what was being, that's what's going to be recommended in terms of how we're screening these kids. One of the advantages we're hoping is that the most of that can be done in terms of a parent report so that it's not going to necessarily be taking up more time in your clinic visit. There are some activities that, again, maybe the parent doesn't see them do every single thing, and you might have to do a couple of those tests in there, but hopefully it kind of expedites and makes the most, expedites the screening process and makes the most of your time. For those children that have symptomatic congenital CMV, the expectation is once they enter into the ID clinic and are seen by them, that they will continue to have their developmental follow-up through the ID clinic. And again, if it happens that a patient has a pediatrician or it seems to work out better for them to be followed at a distance, I'm sure those conversations and logistics can be decided as on a case-by-case basis. Just to highlight again that there are near final decisions regarding the IHP protocol for how to follow these kids in terms of their audiology. Things to know, and again, this won't be anything where you guys have to make a specific recommendation or direction, but just to know that there is a different pathway for children who are asymptomatic and children who are symptomatic from other manifestations of CMV but don't have hearing loss. And really that's going to be multiple surveillance between the first year of, between the first year and until the end of 5 years, because that's when IHP followed kids for. Really, there'll be probably more frequent visits in the first year of life for those children, and those details will be shared with you when that has been completely finalized by IHP. The last bit that I want to kind of come back to is that we haven't had a chance to go over yet is really the reporting outcomes to NSO. And that's on a form that is called the DERF, which is the Diagnostic Evaluation Report Form. And really the purposes for that are kind of twofold. One is to really close out the medical referral. You've seen this child, they've been referred to you, and it's like returning a consult note. And part of it helps to ensure that the program is allowing children to receive timely and appropriate care for those that have been identified through the screen, as well as some quality an evaluation piece for them. So versus asymptomatic, those that have hearing loss, because that's what the screen is about. Are they being intervened upon at the benchmarks that we have that have been set out by IHP, and but kind of what the best practices are, and where are these children ending up? So what it looks like. The elements briefly are, it's going to include your physical exam, the results of your diagnostic investigations, kind of a decision, is this child symptomatic or not? And then where this child is going to next be followed, whether that is with you or whether or not they're going to be referred to ID. And so here's where the draft DERF comes into place. It is a one-page form. It's really meant to be kind of, completed with check boxes and supplying the information. And this is what will be sent back to Andrea after you have seen the child and completed your workup. It's very self-explanatory. So, who the patient is, who they're, who you are as their healthcare provider, the measurements on the physical exam, the results of the diagnostic workup that you did, asking most of the time, you don't have to manually transcribe every single, platelet value, but you can just attach those and fax it back. And then there'll be the determination of these children having symptoms or not, and what those symptoms are. And then how, after completing the assessment, are these children completely asymptomatic, and they will be going into the developmental surveillance stream by a community pediatrician, naming who that person is, or symptomatic, and they will be sent to see Ari and Andrea at ID Clinic. That will essentially, for NSO, is enough to replace what would normally be a consult note. We know that there will be some people who are firm practice, really preferring to dictate their notes. We're asking that this form can be promptly completed as well, and we've tried to kind of standardize it and make it as simple as possible. But if it's easier for some groups or practices to simply fill out this form and send it back, that would suffice for NSO's perspective. There are other things in terms of OHIP, what you have to put in a consult, that would really kind of leave to you guys to do whatever your standard practice is. So that's kind of it for the clinical care pathway. Again, a lot of it is just going over the sort of common clinical care that has been talked about already, but happy to answer any specific questions. And then I think we can also get into more logistical questions if people have that, or concerns or things that have come up at each place. I'll start with the phone, or whoever's on the line.
Hi there, it's David from Mackenzie Health. In your presentation, and thank you for the terrific information, you mentioned mandatory ophthalmology consultation. I think for many of us, certainly around the GTA, having expeditious and accurate ophthalmology assessment will, in a matter of days, will usually require referral to sick kids ophthalmology. And if other people are echoing the same sentiment, perhaps to speed things up, it's just easier for the NSO team to directly refer those patients to ophthalmology and cut the community physicians out of it altogether, because all we're going to do is the same thing.
So you are not alone in having some hesitancy or concern about how realistic a quick ophthalmology assessment is. I will let Ari kind of chat a little bit more after, but I think there have been some conversations to bring ophthalmology at sick kids into the loop. I will say some places have engaged, if they have ophthalmologists that come and do ROP exams at their center, to see if there would be any tie-in to be able to have those patients seen, to eliminate the kind of the load of these referrals to sick kids ophthalmology. But I think, you know, if it makes sense to initiate the referral from the ID office and have Andrea do that, I think that's something that certainly could be talked about. I'm getting a reasonable nod from Ari, for those of you that can't see him from far. And I think from other places that has also been the route that, that seems to work. The one thing we'll just say is that also wanting to make sure that that's part of the medical assessment. So just to make sure that you are kept in the loop as the, I think it would be Andrea referring on your behalf, basically, as part of the program, and it would be still part of your medical assessment. So just to be, you know, make sure that you're still looking out for that. And now I'm going to stop talking and let Ari talk.
Yeah, I don't know that I have a lot to add to that. I mean, we have had some discussions with ophthalmology, and it is the toughest one in terms of timeliness. We recognize that it's going to be a problem, and we actually also feel that it is the least urgent because, and to some extent, this is, we may not always be correct in this, but we expect that having isolated eye disease is, well, to start with, eye disease is relatively uncommon, but we also expect that isolated eye disease is going to be quite rare. So in terms of urgency, it's probably less urgent compared to the blood work, the audiology, and the brain imaging. We have had discussions with ophthalmology at Sick Kids, and we don't yet know how this is going to work in detail because they claim that they don't have resources for this, but they're going to do their best. What they're thinking of is potentially having a fellow clinic or an optometrist be the screener. Some of this is still in flux. But I think the main message is, from my perspective, yeah, I think we maybe can help with that referral. And two, that it is, in my view at least, the least urgent of the investigations that we're going to do.
Yeah, I'd say the only time where it may be a bit more important is if there are some of those soft findings elsewhere. And I can say that's only happened to me once, where we had a child who was referred for a conjugated hyperbiliary that thought was due to something else, and then someone thought to test him for CMV. And then got a head ultrasound with some lenticular striate vasculopathy that was nonspecific, and then there was findings on the ophtho exam. Definitely, absolutely not the most common scenario at all, but for us, it was what kind of made the difference in terms of initiating treatment. So if a child has hearing loss, if a child has any other obvious findings, then wouldn't necessarily wait for, that child should have an ophthalmology exam at some point, but wouldn't necessarily let that hold up the complete, the referral to ID. And then maybe in those cases, they are less pressured to kind of get seen quickly.
Is there any, so could we maybe have a guideline in terms of what length of time would be appropriate? Sometimes I do refer to a community pediatric ophthalmologist as opposed to at Sick Kids. So if the response time back is, what kind of timeline would we be looking for?
Yeah. I guess if I would say two things for that. In a direct answer to your question, I mean, the timeline is still, we're trying to get a decision for these kids by 30 days or prior to 30 days of age so that they can get in to see Ari, you know, prior and start medications by 30 days. For a few of you, we've had kind of conversations to see if it may be reasonable to have your ophthalmologists in the community kind of be part of this. And I would preempt it by starting the conversation early and just saying, you know, just explaining what the program is and saying, you know, there might be however many are coming to the Barrie area, you know, like 5, 6, 10 a year. So there may be one-offs when someone might need to be seen, and we would ask for that to be done, you know, within like a week's time, probably. Again, if you get the result on a child that you're seeing at, you know, 8 days of age, it's less of a panic than maybe a kid that's only gotten to you at 6 weeks of age, in which case you're going to want to try and sort of have that decision be clearer for referral. Does that answer? Okay.
Sorry, hi, it's Leah Tatum from Scarborough. Just to clarify, because I'm on the phone, are you going to be sending us everything that we need to do when we see these kids for the first time?
Yeah, great question. So once at the time that you're going to be receiving the medical referral from Andrea at the ID office, it will have the information. It will have a copy of the DERF, and and then if we'll always, which will be basically like a checklist. But then there will also be the guidelines that if you don't have them already, that the ID working group is going to have. Those can be sent to you at the same time. I think.
Okay.
Yeah, is that okay?
So at the first appointment, they need, like, we want them to get a head ultrasound, physical exam, history, and blood work or urine? I'm just not clear.
Okay. No, if you're not clear, then probably a couple people aren't clear. So glad you asked. Yes, so we'd definitely send so as we've kind of gone through, the test itself, the dry blood spot isn't the most sensitive test, but it is definitely specific. So I would not wait, as you brought the child in, to do for the confirmatory urine to come back before doing the rest of the workup. So at the time they see you, it would be to send a bag urine, and again, it doesn't need to be a sterile specimen at all, so you don't have to cath them. It would be to arrange the head ultrasound, do the blood work, and then your physical exam assessment. If possible, to kind of tee those up at the same day. Again, that's ideal for the families, but we know that's not practical for a lot of people.
Right. Okay. Thank you.
Oh, pleasure. Hey, Melanie.
I was just going to ask, for those who are on treatment with antivirals that need the blood work screening, weekly for the first 4 weeks, then 2, and then Q4 weeks, who will be following up on that lab work? Will it be us? Will it be ID?
So I guess for the ones that are followed at sick kids, it depends a little bit. The ones that are close to me, I'm happy to follow up on those. What I usually do is I see them once a month, and I give them outside requisitions if that's their preference for the weeks in between. So they do them outside with referral to me. Ones that are a little further away, and to some extent this comes down to their preference too. I've had ones where I've done a more mixed, where they see me every 3 months as opposed to every month, and they see the pediatrician in between. So it kind of can be a case-by-case basis. It depends a little bit what the family's preference is as well.
Any other questions from the phone that are on there?
Sorry, I guess just another question about the ASQ. I don't currently have the ASQ. I don't use the ASQ. I do a look-see, and I do my own developmental assessments. There was talk about funding to get the ASQ?
Yep.
Yeah.
You will have it. Okay. Lauren's just taking note of that, and we'll get you a starter kit. And once you have it, you can, if you so desire, you can use it for obviously anyone else in your practice as well. So if it's there, yep. Happy to provide that. If there are no other questions about the about the last topic, maybe now for the last half hour, we can open it up to any concerns or any questions that people have had in discussing the program with their group, or feel free to, I'm sure Pranish would be happy to talk about genetic mitochondrial hearing loss questions again, if someone wants to go down that path. But I think at this point, we can just, open it up a bit more generally if there are questions out there. Because certainly if one person has them, someone else does too.
Sorry, we've tried to engage ophthalmology at North York and haven't really had a response. So I'm going to do a third round of emails, but I have a feeling it's futile. So I'm guessing from July we refer to sick kids ophthalmology.
Is that okay?
Yeah, in speaking to the chief of ophthalmology, at Sick Kids, he did have some concerns about what might happen in the community, and he felt that the majority will end up having to come to Sick Kids, which he was worried about because of the load. So we'll have to see how this goes, and we might have to prioritize. But I do agree that maybe the referral, maybe that should be something that we do, that, it's not on the pediatricians.
Yep, that's up to you.
Yeah.
I think in that case, it would just be that if the referral came from, from Andrea, that it would be, be sure that it was made on behalf of whoever, and then the behalf of whichever pediatrician is requesting it. But then there's almost like a safety check that both the referring pediatrician will get those results, and that as well the the BID center would too, which is really, most important if there's any findings, right? You don't need to rush back to say, oh, it was perfectly normal. but I think, sorry, that just reminded me of something else that will be confirmed, I think, going forward with each lead agency, because there are 3 that are kind of serving in the Toronto area. But the intention will be that there will be like direct communication for children who have found to have hearing loss on their diagnostic assessment, and by that I mean just sort of some direct conversation with either, whether that's the NSO or with the referring pediatrician, so that the child who would need to be seen by ID and kind of have not only audiologic intervention potentially, but ID intervention, that just doesn't kind of get lost in a bunch of faxes that are going to people's offices and stuff. So for those important findings.
Hi, Melanie from Aurelia. Sorry I was late. I'm coming to part of this one and part of the next one. In our group, we had talked about, should we try and incorporate it in with our neonatal follow-up program, but it sounds like from this that that's really more than we need, that this can just be an office visit with an ASQ. Is that right?
I think some people have found that it's going to work really well to go into their neonatal follow-up, and other people, for logistical reasons, have found that the office-based is fine. So, I think there may be some children who seem to be quite, maybe they've got other reasons, like they're CMV positive and they were PRAM, or maybe they had some other, HIE at birth that would be in the neonatal follow-up, and maybe they would benefit from that more thorough assessment. But I don't think we're trying to be prescriptive. It's just to make sure that there is follow-up for these kids because they are at risk. And if I can insert, sorry, one thing that was really interesting to me to learn at the last CMV conference about 2 months ago, not to learn, but to really understand better, was there's a presenter that came from Sweden who really talked a lot about the vestibular dysfunction in asymptomatic children, and it was actually quite remarkable. And I know that Sharon Cushing, who is the ENT here at Sick Kids, and also kind of, I think, the director for the cochlear implant program as well, or? Okay. But one of the cochlear implant ENTs, but also someone who's definitely been heavily involved from the ENT perspective in this program, has also made that observation at home, maybe on her own, and maybe it's just these kids are a little bit more clumsy, but sometimes, the tone isn't great on these kids, or their heads are a little bobbly, and so those are things that I think will perhaps become more evident as these kids are being followed a little bit more closely and benefit from that developmental follow-up. I think, Melanie, I think they want you to
I'm sorry.
turn your UN mic off.
Hi, I was just wondering, because we also have a neonatal follow-up clinic that we do to follow developmentally with early interventions and also physiotherapy, like any newborn babies that had been through the NICU. We had been thinking on implementing it through it as well, like for the developmental follow-up, but for the initial assessment when the patient has been positive, we had been thinking on bringing them directly to the urgent care clinic, so it will be faster to be seen, like basically it's a fast track for those patients, so that right away we can do, and that will be the pediatrician who is on call doing those assessments. So it's not necessarily like a straight one pediatrician is going to be doing it, but hopefully we'll get the investigations done on them faster. So I'm not sure, this is on the books, so on written, so it's not yet tested, so I'm not sure how it will work, but hopefully we would be able to do so, as well as we do have ophthalmologist that comes every 2 weeks to do eye examination, and we have in hospital head ultrasound that will also be helpful to do all the assessments. So we're trying to tie it all together, but I'm not sure how it will roll when it just starts coming in.
I was just going to say, I think that sounds like that sounds great. You know, the couple of things we were trying to achieve. One is obviously timeliness of the initial assessment, and you know, I've heard from several people exactly that concept of what you're saying. You know, to have them come in that setting for the initial follow-up, and then in terms of the ongoing care, whether that's in the neonatal follow-up clinic, in some places it sounds like that's going to fit very well. In other places, it may not. One thing that's come up as a bit of a theme is if the follow-up is not happening in the neonatal follow-up clinic, if a baby is found to have some risk indicators coming up on the ASQ, some you know, concern coming up either through the ASQ or through you know, just clinical assessment. Some places have also talked about then pulling them into the neonatal follow-up stream at their institution as a third, you know, variation I've seen on that theme. So again, I think the you know, what we had sent around in the emails with that schedule of the, you know, within the first 3 years, you know, first year, you know, 3 assessments, you know, following year, you know, 2 to 3 assessments, and then annually after that. In part, that's mirroring what will be used as the developmental assessments in that study that Ari mentioned, where they're looking at sensorineural hearing impairment as the only indication for valganciclovir treatment. And part of the reason I'd like, you know, ideally we would see that as a minimum sort of developmental surveillance for these kids is if that study, when the results come out, it will be a large study, and we'll be able to compare our kids, you know, with whatever they observe. So I would sort of see that as a minimum to aim to have them in. Certainly, some of the neonatal follow-up programs have a more intense follow-up. I think if the parents are willing to do that, I don't see a harm in that. What would be unfortunate is if many of them fall out of the developmental surveillance and we don't pick up those kids who may be you know, at higher risk.
We do even follow up kids that had been not premature or had not been in the NICU at the neonatal follow-up clinic, and babies that had been, for example, diagnosed with meningitis during the first month or 2 months of life, to make sure that they do fall into the follow-up. So thanks God, so far we have been able to manage that amount of patients. I don't know if there will be a lot of influx coming from the CMV clinic or the positive patients that arise from the screening that will overflow the capability of our clinic, but hopefully, well, I don't know if there's any other resources in terms of funding that will be coming along with this, also in terms of getting more physiotherapy or early interventions along the line to keep these follow-up ongoing as well. You know anything about it?
I think that these kids that if they have some impairment, right? So if they are screened positive on the ASQ or their developmental surveillance that you do, then these kids really would be falling into either CTN or early intervention services, just like any other child. Just like these children probably are falling into right now, we just may not know that they have CMV, right? So I think it'll end up being the same resources. It's just that we're seeing these kids differently, or that we're seeing them before they might have actually those impairments, I'm assuming.
Good point.
And that is the expectation, and that's how this was conceived and presented, you know, to government, was that these, you know, of the kids who, I mean, the major morbidity here, to use the term morbidity, because we're in a medical setting, is the permanent hearing loss, right? And so, you know, as one of our slides mentioned, the incremental developmental disability is actually quite small outside of the hearing loss. You know, it's really those kids with more severe symptomatology who are likely the ones who already were being identified as needing the more intense services from a developmental point of view. It's unlikely that we're going to have significant significant increment from the asymptomatics or those really mildly symptomatic kids. One other thing I wanted to mention was in terms of when everything starts. I've been emailing and in the phone call saying mid-July. So I think there's a couple of key milestones that still have to be hit at the government level. But the way we're communicating the start date now is that the earliest start date will be July 29th. And the reason for that is there's one regulatory change that has to go through in terms of lab licensing. It's anticipated that that's going to happen July 1st, in which case everything will proceed nicely. We can start. The first consents would be taken July 29th then. I think it sounds we have our next phone call to confirm where things are at with this regulatory change. And again, has to do with lab licensing, allowing us to do this as a screening test in Ontario. Our next update is tomorrow, but thus far it looks like everything will be in place July 1st. But I have a feeling we won't get that final, yes, everything was signed until July 1st when it's signed. But I think we're operating at about 95% confidence that it'll be July 29th as the first date that consents are taken.
I just wanted to take a chance. I'm not sure if there is anyone from IHP on the phone on this part of the call that had anything else to add from their perspective about the screen or anything else that they wanted to clarify or correct that I may have mentioned.
Hi, sorry, it's Angela Derbyshire from Toronto Infant Hearing Program. I was trying to unmute myself. I think you guys
We hear you.
You guys did an amazing job capturing. There was some new information for me today, so it was really interesting to see the different aspects of it.
Any concerns, Angela, from the IHP that you wanted to highlight to the captive audience that we have right now?
I think our concern is always going to be timelines. How do we get these babies quickly and into and through our systems?
Yeah.
So there's early discharges from some of the hospitals, if there's a 4-hour discharge, midwifery deliveries, births at home. So we're just trying to figure out how we can capture all these babies.
Yeah, I think that's going to be interesting. When Utah, and I think they were among the first to kind of implement their targeted hearing screen. So any baby that referred initially got a CMV urine done, they noticed over the first 5 years of their program, from their hearing perspective, that their benchmarks as awareness, came, and they started to see a real change in terms of how more quickly kids were being brought in. And I think they have a population where there may be a significant amount of kind of outside hospital births and that as well. So we'll see how it lays out, and I'm sure there's going to be a lot of lessons, but I wonder if their experience is going to kind of foretell anything for ours as well, in terms of highlighting some of the timelines that are longer than any of us would like, and then being really mounting to that challenge after.
Well, I can only speak for Toronto, but we've worked really hard to bring our average age at time of community screening down. So in the last couple of months, our midwifery age has dropped from about 3 to 4 months of age down to 28 days. And our babies who were missed pre-discharge had dropped to about 17, 18. And right now we're just trying to stabilize some of that and reduce it a little bit further.
That's awesome. Things are moving the right way. That's great. I'm looking at some of the NSO people here, if there's anything else that they wanted to mention, add on, share. Maybe then, certainly I think all of us are available to be contacted. And I think, if you don't have any of our direct, all of us, sorry, I'm thinking of Planish, Lauren, and myself that there is the NSO hearing at chio.on.ca, which is a general email that can get to us if you don't have, I won't spell out all of our own. And then I'm sure as well if there's logistical questions about ID and ticket things that Ari would be waiting with bated breath to answer all the calls for or emails. So please don't hesitate to reach out as things come up, and maybe we'll uncharacteristically kind of finish up a little bit early and give people before the next round comes in a chance to stretch their legs.
Yeah, I totally agree. I think it's time to stretch our legs, but also just that Andrea has joined as the nurse practitioner in Toronto, and so that's really great. And part of the role is also to help with the coordination within the region. So if you're thinking about contacting me or Jess or Lauren, think of Andrea in the same breath, and she will get to know this region better than I ever can sitting in Ottawa, for example, even though I did go to high school in Mississauga and undergrad in Toronto and did my fellowship
Junior high
here.
in Calgary.
But I'm not a Torontonian anymore, right? So, but just again to plug, Andrea will become the person who knows this region best from this program point of view.
Yeah.
Last quick question. Are you guys going to distribute the slides? It's Melanie and Mississauga.
I think so.
I think yes, as well. We'll send a link for the recording of the session, and we'll make sure we have all those recommendations from the ID working group out in time for the program start. And so, yeah, I think you'll have both access to these slides, the presentations themselves, and the documentation you need.
Yeah. Great, thanks.
Hi, it's Lauren. I'd just like to add one housekeeping item. For those of you who have joined via Zoom, I caught most of your names, but unfortunately the way the recording is set up is it's recorded your name however you've entered it, and some people have nicknames or no names, and so I'm not actually able to figure out who you are. So if you're on the line and your name isn't registered in Zoom with your actual name, if you could just send an email to the NSO hearing account to let me know that you joined, just so that I make sure to send you an attendance certificate for CME credits. That would be wonderful. Thank you.
Thanks everyone for your time today.
I just have a quick question, maybe more relevant for me, given that I'm in my second trimester. But just wondering about like PPE.
Ari's accepting prenatal consults. Right? No, I'm kidding.
I already asked with my first one, if you remember, 2 years back, but I'm feeling a little bit more comfortable. In terms of PPE, when we're examining these babies, obviously now I'll be a little bit more strict, but should we all be wearing, like, should we drop-in precautions, contact precautions? Like,
I'll let you go.
I would say standard precautions. So if you're just examining someone whose status you don't know, just nothing. If you're changing someone's diaper, I can't see you doing that so much on the ward, but if you are, put on gloves. Yeah.
And I might just tag on to that this is the patient that you know that you're seeing for that reason, and you might have a heightened awareness, but the true disseminators of this are those like toddlers that are coming in with daycareitis or with like hand, foot, and mouth or something else that will just be asymptomatically shedding things. So just having that many of them are a portal of CMV. So yes, and I mean I say that jokingly, but just really because we get that question a lot for kids that we know that are admitted with CMV that happen to be in the hospital for other reasons. A lot of apprehension from nursing staff and whatnot, and so it's really about standard hand hygiene.
I have just maybe a comment, maybe a question. I was just at a talk. We had a bit of a round at our center from one of the ENTs and our infant hearing program about the CMV and the rollout of this actually. And there was a family doctor in the audience, and then I think an obstetrician as well. And there's a discussion about, well, wait a second, like, is this being discussed by family physicians and by OBs at their prenatals, specifically with regard to that one slide that you guys have about preventing the spread of CMV? And I don't think there is. Is there a push, or as part of this, is there a public health initiative or something to kind of talk a little bit more about that? Because the conversation really shouldn't be had about when you're seeing the patients or when we're seeing the patient with a positive CMV about to the moms about, you know, how to prevent this. It really should be ahead of time. And is that being discussed at all? And also, I guess the other thing was that the OB group had also asked, well, wait a second, should we be actually screening our moms? And I know the answer to that now, but I don't know if that is actually well known by people that are actually treating these moms.
I'll touch on that briefly, and then I'm sure Ari's got something wiser to say. But initially, there was a little bit of concern, I would say, by some of the OBs that where they're, you know, who have had some other involvement, you know, from the either high risk or about this program coming out and how it was going to implicate the prenatal care providers. So a couple things that I would say are, one, there is a revision of the SOGC statement that is going to be coming out that is going to have all these recommendations about hand hygiene, you know, the soother, cleaning it with your own mouth, which is probably dirtier than your baby's mouth, and you know, not kissing your baby open mouth and washing hands and all that other stuff. So there is a statement that from some OBs who are, you know, involved with the CMV advocacy that will be coming out. And I think it's supposed to be coming out within the year. I thought it was going to come out in 2019, but it might be early next year. So that's one. I think number two is that for reasons explained, no, screening isn't really indicated, but there are a lot of things that we don't necessarily screen for that we do give advice for. And that's like alcohol, you know, not changing the cat litter, you know, all that other kind of stuff. And I think as we're starting to see how, I think as CMV is starting to gain a little bit more attention, we're going to see how common it is, and then the word will spread. And I think that counseling will hopefully become more routine, because I can say that in Ottawa, similarly, many of the parents who come in and we and sort of have a conversation about CMV and where it came from, their first thing they do say, just like Ari said, is how come nobody told me? Whether or not it was completely preventable or not, probably not, but how come nobody told me? So I think that movement's going to kind of get a bit more momentum. Yeah. Okay. All right, for real break. Thanks to those who held on the line.